Yeah. Good evening, everyone. Welcome to the weekly webinar series conducted by AHNOK and HCG. We are on the fifth talk on the neck module, and to discuss today, we have one of my teachers who has again mentored me through my journey in head and neck, Professor Krishnakumar Thankappan, who will be talking about adjuvant therapy in neck metastasis. Thank you for sparing your time and agreeing to participate in this webinar, sir. To moderate this session, we have Dr. Vivek Shetty, who is a head and neck surgeon with a special interest in reconstructive surgeon from reconstructive surgery from Mazumdar Shah Cancer Center. So, Dr. Vivek, welcome to the webinar, and over to you to moderate the session. Dr. Vivek?
Vivek is mute. Yeah, he's talking.
Hello. Hello, good evening, everyone, and welcome to the session on adjuvant therapy in neck metastasis. Krishnakumar sir is going to be talking about this. This is a very important topic because, as we know, the most common cancer in head and neck is the squamous cell carcinoma, and the survival is grossly affected by presence of neck metastasis. And it's important to know when to give radiation and when to give chemoradiation, and if there are any situations with metastasis where we can observe the patient. So without wasting further time, I'd like to hand over the mic to Dr. Krishnakumar to start the talk, sir.
Okay, good afternoon, everyone. Thank you, Akshay and Vivek. You're doing a wonderful job by hosting such webinars and taking initiatives for learning and teaching. So let me just share my screen. Are you able to see my screen?
Yes, sir.
Okay, so the topic for today is adjuvant therapy in the neck metastasis. Adjuvant therapy is a treatment given to the patient after the surgical treatment. Today for the talk, we will be dealing with the squamous cell carcinoma in head and neck cancers. I'm not going into the other salivary or thyroid pathology, but we'll talk about squamous cell carcinoma. What are the factors warranting adjuvant treatment? The factors can be primary or tumor factors or nodal factors. Today we are talking about nodal factors. What is a rationale for adjuvant therapy? Unfavorable prognostic factors have a high risk of locoregional recurrence and subsequent worse survival after surgery alone. That's proven. And it's possibly due to the unidentified microscopic residual disease. And most optimal adjuvant strategy should be based on the most important prognostic factors. Okay. Now, what are these prognostic nodal factors? It can be either presence of metastatic node, the number of involved metastatic nodes, overall nodal yield in neck dissection, the level of involved nodes, and lastly, extranodal extension. So these are the nodal factors which has to be considered as prognostic when we think about adjuvant therapy. Now, coming to each one of them, the presence of a metastatic node, PN+. We have done the surgery, and in pathology, we have found a node PN+. So this has been proven to be prognostic. This is one of the very earliest papers by titled Combined Neck Dissection and Postoperative Radiation Therapy in Management of High-Risk Neck, a Matched Pair Analysis. a paper which came out in 1980 or something. And here below you can see the graph. When the PN plus patients were treated with surgery alone or surgery plus radiotherapy, the neck recurrence free survival and overall survival was better when radiotherapy was added. So the presence of a metastatic node itself is a factor that warrants adjuvant treatment. Another paper talking this same thing, adjuvant therapy improves overall survival for patients with a lymph node positive head and neck squamous cell carcinoma. Here again, showing the improvement in survival. What about the number of metastatic nodes? Here is a paper from JCO talking about the metastatic lymph node burden and survival in oral cavity cancer. They looked at the various PN stage, like based on the number of the nodes. This blue line is 0 lymph nodes, then 1, 2, 3, 4 to 6, 7 to 9, and more than 10. Again, the overall survival was best when there were no lymph nodes or PNs. And worst was when there were more than 10 lymph nodes in the neck dissection. So number of metastatic lymph nodes is also important. Now there's something called as lymph node ratio. It is a ratio of the number of positive lymph nodes to the total number of lymph nodes removed in a neck dissection. This has also shown to be a prognostic factor in head and neck cancer with better survival in some papers. Now, there is some controversy about a single positive node in neck dissection, PN1. Okay, PN1. There is only a single node positive, especially when the node doesn't have an extracapsular extension and when it is less than 3 centimeter. Whether that such a node demands a adjuvant therapy or not. This has been in discussion and studies by many people, but mainly by the MD Anderson group, by Peters, Ang, and the group. So the first paper, they tried to risk stratify based on the nodal factors here, based on the number of the nodes, the size of or extracapsular extension, direct invasion, and they divided into low risk, intermediate risk, and high risk. And this number of nodes, when it is 0 or 0 to 1 without extracapsular extension or any invasion, it was considered a low risk. And finally, they could find that such patients could be observed. So when we talk about the classical indications of adjuvant therapy, a single positive node is supposed to be not an indication for adjuvant therapy in all classical or papers. But there are some few, when you look at the literature, there are also papers saying that this pathological N1 disease also needs to be given radiotherapy, like this paper. And there is a person called Maximilian Morgel. I think he's from UK. He has looked into this particular factor alone and did a meta-analysis alone. And then later he planned a randomized controlled trial. Okay, effectiveness of adjuvant radiotherapy in patients with oropharyngeal and floor of the mouth squamous cell carcinoma. Mind you, this is a combination of oropharyngeal and floor of the mouth carcinoma. And concomitant histological verification of a single ipsilateral cervical lymph node PN1 state, a prospective multicentric randomized control using a comprehensive cohort design, whether radiotherapy or not. But for some reason, we just saw the protocol of that trial. We have not seen the results of the trial. Probably it is going on, or I'm not sure whether they have suspended the trial. But the classical teaching is that when there is only a single lymph node and when there is no extracapsular extension and when it is less than 3 centimeters, it may not warrant adjuvant treatment. Now coming to the nodal staging, probably you might have gone through this in one of the previous webinars by the same group. So it can be clinical or pathological. AJCC 8 is similar to AJCC 7, except that they added a N3B, that is clinical extranodal extension. So I'm coming to the last prognostic factor, the extranodal extension. So clinically, any lymph node with the clinical extranodal extension is clinical N3B, and similarly, any single ipsilateral node less than 3 centimeter with extranodal extension is N2A. If there is no extranodal extension, it remains N1. But if there is extranodal extension, and when the node is less than 3 centimeter, is N2A. And when it is more than 3 centimeter and with pathological extranodal extension, or any node with ipsilateral, bilateral, multiple ipsilateral, bilateral, or contralateral node with extranodal extension, it is N3B in pathology. So I'm just highlighting the importance of extranodal extension that they have incorporated into the AJCC 8th in staging. And AJCC 8 has incorporated high bar of extranodal extension to prevent stage migration and unnecessary upstaging. Only unambiguous extranodal extension by clinical examination, for example, invasion of the skin, musculature, dense tethering to the adjacent structures, cranial nerve dysfunction, brachial plexus, sympathetic trunk, or phrenic nerve, and supported by radiological evidence. Radiological evidence alone is not enough to prove the clinical extranodal extension. And pathological extranodal extension can be minor or major. Minor is when the extranodal extension is less than 2 millimeter or less from the capsule, and major can be extension apparent to the pathologist's naked eye and feel, or more than 2 millimeter from the capsule, or when there is soft tissue deposits without nodal architecture. Either major or minor is considered for staging. And there are papers which have looked into the prognostication of extracapsular spread. For example, this paper concludes that ECS is a major prognostic factor in head and neck squamous cell carcinoma. No standardized histological diagnostic and grading criteria are available for ECS, and there is a correlation between the level of extension and poor prognosis. Now, what are the indications of adjuvant therapy? So we have seen the prognostic factors. So what I've listed is a classical indication for adjuvant therapy after a neck dissection in a head and neck squamous cell carcinoma. Advanced T stage, here again there is a little bit of controversy whether it is advanced stage or advanced T stage. Okay, classically speaking, or in the randomized controlled Bernier-Cooper studies, they have talked about the overall staging. But if we say overall staging is an indication for adjuvant therapy, then T1, T2, N1, okay, T1, T2, N1 without extracapsular node also becomes stage 3, and then we may have to give adjuvant therapy. So if we agree that a single node without extracapsular node and less than 3 centimeters is not an indication for adjuvant therapy, overall staging like stage 3 or stage 4 cannot be fully considered as an indication for therapy. So then it would be best to say advanced T stage, and then list other factors like presence of lymphovascular invasion, presence of perineural invasion, positive surgical margins, and among the nodes, the highlighted ones are the nodal factors: multiple lymph node involvement, that means 2 or more, low level nodal involvement, meaning that level 3 or level 4 or level 5 nodes, and obviously extracapsular nodal extension. These are the indications for adjuvant therapy. Okay. Now, what is the choice of adjuvant therapy? Either whether we should give just radiotherapy or chemoradiotherapy. This question was answered by 2 people. One is Jacques Bernier and J. Cooper, EORTC and RTOG. They separately did randomized controlled trials, and they laid out the indications for giving chemoradiotherapy and not just radiotherapy after head and neck cancer surgery, including neck dissection. So finally, they pooled the data. Okay, the Cooper was behind this RTOG, and Bernier was behind EORTC, and finally they pooled the data, and this is the Venn diagram. So EORTC indications for chemo is like stage 3 and stage 4, as I told. Stage 3, stage 4, oropharyngeal oral cancer with level 4 or 5 lymph nodes, lower level nodes, perineural disease, vascular embolism, margin positivity, and extracapsular extension. These were the indications by EORTC. But by RTOG, they had margins positivity, ECE, and 2 or more positive nodes. And when they pooled, what did they find? The margin positivity and extranodal extension were the significant factors that would demand addition of chemotherapy as adjuvant treatment. So if somebody is asking you what are the indications of adding chemotherapy or when do you give chemoradiotherapy as adjuvant? When there is margin positivity or when there is extracapsular extension in the nodes. Now, what is adjuvant radiotherapy? What is the dose and details? The radiation dose is 60 to 66 gray in conventional fractionation over a period of 6 to 7 weeks. It's a external beam radiotherapy. And the conventional fractionation is a dose of 60 gray in 30 fractions to the surgical bed and the first echelon nodal stations. And the low risk nodal stations, that means that the nodes which came negative on neck dissection, the levels which came with nodes which are not positive, can be treated with the 50 to 55 gray. And the high risk features like perinodal spread patients are treated with the concurrent chemoradiotherapy, and then those high risk regions have to be treated with a total dose of 66 gray. So that's the regimen for adjuvant therapy. And what is a chemotherapy? The radiotherapy should be concurrently given with the high dose cisplatin, 100 milligrams per meter square once every 3 weeks on day 1, 22, and 43. This is the classical regimen. Cisplatin, 100 milligram per meter square once in every 3 weeks. There is also another school of thought that cisplatin can be given once in every week. I'll come to that. And if the patient is not tolerating cisplatin, there are instances when we replace cisplatin with the carboplatin. So this is a paper which came from India, from Tata Group, Vanitha Norona et al. They looked into whether once a weekly regimen or once every 3 weekly cisplatin is good for chemoradiation for locally advanced head and neck cancer. And they concluded that once every 3 weeks cisplatin at 100 milligram per meter square resulted in superior locoregional control, but with more toxicity than did once a week cisplatin at 30 milligram per meter square. And the 100 milligram per meter square should remain the preferred chemoradiotherapy regimen in locally advanced head and neck cancer in adjuvant setting. So what is the importance of this study in this talk? They had 90% of the patients of oral cavity cancers. It was done in Tata. And 93% of the patients received chemoradiotherapy in the form of adjuvant treatment. And 90% of the patients were node positive. That's the relevance of this particular paper in this talk. And they saw better locoregional control and progression-free survival with the once a week the cisplatin. Last point about the time factor. When we consider about the time factor, two things has to be seen. What is the interval between the surgery and the start of the radiotherapy? And the second point is total treatment package. That's the interval between the start surgery and the end of the radiotherapy. So coming to interval between surgery and the radiotherapy. This is a paper which classically looked into it by Huang et al. It's a systematic review with 7 studies involving 851 patients. Association among patients with head and neck cancer treated with surgery and postoperative radiotherapy, and they found locoregional recurrences was higher among patients that started radiotherapy more than 6 weeks after surgery compared to those that started radiotherapy within 6 weeks. So this is the paper that is behind the classical teaching, saying that we have to start radiotherapy at least within 6 weeks of surgery. And the second point, a second factor in the time is total treatment package. Again, this was from MD Anderson group, the Kian group et al. They looked into the interval between the surgery and the end of the postoperative radiotherapy, and that is called as total treatment package. And the loco-regional control as well as the survival, here particularly the loco-regional tumor control rate was 74% and significantly better among the patients treated when the total treatment package was less than 11 weeks compared to 61 and 41 when it was 11 to 13 weeks or more than 13 weeks. Okay, so ideally you should start the treatment after within 6 weeks, and the total treatment should be over within 11 weeks. So summarize the advanced stage treatment. They should undergo surgery, including neck dissection, and the surgery will be resection of the primary and ipsilateral or bilateral neck dissection. And when there are adverse features, they should undergo either radiotherapy or chemoradiotherapy, especially when there is extracapsular spread or positive margin. Otherwise, it can be just radiotherapy. And the radiotherapy has to be started within 6 weeks of the surgery, and it has to be over within 11 weeks. Thank you. Thank you. Dr. Akshay?
Thank you, sir.
Yeah.
Vivek?
I think Dr. Anup is also from. Anup, are you here? Are you there? If Anup from Amrita, is he there? If he's seen, maybe you can unmute him if he has any points to add. Our radiation oncologist.
Just 1 second.
No problem.
Hello, Vivek.
Hello. Yeah.
Hello. Hello, sir.
Hello.
Thank you. You covered the topic excellently well.
Yes, Anup. Yeah.
And the confusions regarding, I was just going through the questions. You excellently covered when we are using the 3-weekly and when we are not using the 3-weekly.
Yes.
Actually, as I said, the evidence was been more favoring the 3-weekly regime until now. But with the Tata Memorial Hospital paper coming up, showing a non-inferiority of the weekly cisplatin versus the 3-weekly cisplatin, more of the institutions are favoring a weekly cisplatin package for the convenience of the patient and for a better tolerance of the Indian patients.
Correct. Only one point is that they have only looked into the 30 milligram per meter.
Yes, sir.
But they have their own justification for that too.
So the cumulative dose of approximately 200 milligrams, that was the cutoff point they were taking up when they're having equivalent comparison. And with the newer schedules of approximately 30 to 33 fractionations of radiations, majority of the patients are not taking up the third cycle of cisplatin concurrently. So that was the reason why the cumulative dose of 200 milligram was taken as a cutoff line. And most of the time, it was found to be equal or non-inferior to the 3-weekly regimen followed.
Yes, and that's more feasible and practical in Indian situation too.
Yes. The second thing was when to use a carboplatin. I was going through one question: when do you use a carboplatin when you are having a concurrent chemoradiation?
Yeah.
So the issue is that you look up the toxicity of cisplatin.
Yes.
So cisplatin needs a hydration protocol. So the patient has to have a good cardiac function. Also, then the renal parameters as well as the autotoxicity of cisplatin has to be accounted for.
Yes.
So
especially when the patient has a compromised renal function, we may go in for a carboplatin.
carboplatin.
Yes.
So is
No.
yeah.
Yes, Akshay.
Yeah, just couple of questions. I'm just thinking if Vivek is there online, so he can ask the question.
Yes, I'm here. Hello, sir. We've got a few more questions, sir. Some very basic questions. One of them
Yes,
wants
please.
to know when exactly we use the term adjuvant treatment.
Adjuvant is the treatment of the treatment given after surgery. There is a confusion. There is no confusion for the adjuvant terminology, but there is a confusion between the neoadjuvant and induction. So that is used interchangeably sometimes. So adjuvant is when any treatment is given after surgery.
And some more questions, sir. One of them is, what is your opinion on metronomic treatment, and when is the appropriate time to use that?
Metronomic, there is clear evidence, and this time they have Tata has presented a paper in ASCO 2 about the importance and the literature support for metronomic chemotherapy. In a metronomic chemotherapy is small dose chemotherapy given repeatedly in a palliative setting. Anup, anything to add?
It's not used in the adjuvant setting at all. It's always used in the palliative setting.
Palliative setting, yes.
And what are the indications for bilateral neck irradiation following, even when there is ipsilateral disease? Is there any indication to give radiation to the opposite side of the neck?
Anup, do you want to take that question?
Yes, I shall take. So normally, whenever the lesions are the primary site of origin is a central tumor, basically as the tongue or floor of mouth. Normally, there's a higher chance of lymphatic drainage to both sides of the neck. So in such situations, it is always prudent to address both sides of the neck with radiation, and the lymphatic drainage and the pattern of failure suggest which all nodal stations to be addressed. So we usually limit our radiation to ipsilateral side only in cases of patients having a buccal mucosa, carcinoma buccal mucosa or gingivobuccal sulcus lesions, and and it is usually limited to one side alone. If the nodal burden is the number of lymph nodes are not very high, if it is an N1 or small lymph nodes, or maybe if it is N1 or ipsilateral lymph nodes alone, on one or two stations, if it is confined and it is not having any external extension, then probably the benefit of adding radiation to the opposite side is very less. So the current recommendation says that if a buccal mucosa or gingivobuccal sulcus lesion, if there is an N1 disease, you have to limit your radiation to one side alone. If it is an N2, then it's a debate whether to go with bilateral radiation or to still fix to one side is a debate. So in such situations, if the nodal burden is on the higher side, majority of centers prefer to treat the opposite side of the neck as well with a lower dose, prophylactic dose.
So the ipsilateral, commonly for tongue, especially if it is T3 or T4 tumors, or if there are bilateral nodes or floor of the mouth tumors, usually it is bilateral neck radiation. Yes. And unilateral radiation may be limited to buccal mucosa when the nodal burden is less and is limited to the upper levels.
Sir, and your comment on re-radiation, after how long can we consider adjuvant re-radiation in case of second primaries or recurrences?
Yeah, re-radiation usually because of the advances in radiotherapy, it is being considered more and more now. We usually wait at least 1 year after the initial radiation, and the recurrences or salvage surgery should have, the pathology in the salvage surgery should have a definite indication for adjuvant treatment again. And if they have finished 1 year of treatment, we may think of adjuvant re-radiation. If it is a small recurrence and if we could clear it fully, we may not think of re-radiation. But it's a large recurrence, or if the margins are close, or large nodes with extracapsular nets in the salvage setting, and the patient has comfortably passed at least 1 to 2 years, we may consider re-radiation, sparing vital structures using advanced technology like IMRT and so on.
And one more question. They would like to know, is there any indication for concomitant cetuximab by itself or along with the cisplatin while giving the RT?
Yeah, that too. Sometimes we replace the ideal should be cisplatin, and when cisplatin is not there, or when there are certain indications, we may consider cetuximab, like in elderly. But recent papers, for example, after robotic setting, they have come up with the paper saying that cetuximab is not ideal. It should not be considered. That's the latest evidence. But the previous thinking was it can sometimes replace, the toxicity is less. Anup, do you want to add anything about cetuximab?
Cetuximab, we also consider only when the patient is not fit for a concurrent cisplatin.
Right.
And majority of the patients are explained about toxicity of cisplatin, and if they are agreeing to that, probably then cisplatin is the first line choice. But in case if they have any concerns like hearing issues or have impaired renal issues, then in such situations cetuximab is offered.
Okay.
And recently there have also been trying with nimotuzumab and cisplatin concurrently together in certain situations. Under a trial setting, it has been done under Tata Memorial Hospital. It's not become a randomized, it has been a randomized trial, but it's not come as a proper evidence yet.
Any other questions? Hello.
So,
Yeah.
so one last question. Is there any role for hyperfractionation? That is one of the questions asked. Is there any role for hyperfractionation?
Anup is a better person to answer that.
Hyperfractionation is actually when you are giving more than one fraction per day. And that you're always giving. Normal conventional fractionation is approximately 1.8 to 2.2 gray per fraction. You're giving one fraction on every day and 5 days a week. Whereas in hyperfractionation, it is actually more than one fraction every day, and it is done 5 days a week. So the fraction dose is on the lower side. The advantage is that probably the radiobiological advantage is that whenever having a dose per fraction is on the lower side, the long-term toxicities are less. But since you're treating on in the morning and evening, at least 6 hours apart, the patient has to be treated. So in such situation, the acute toxicities are almost same or slightly on the higher side, but the long-term complications like the fibrosis is actually on the lower side. So you choose patients whom you expect a higher chance of having a long-term complication if you're seeing across them. And then in such situation, you can definitely consider hyperfractionation if you have the feasibility, because treating a larger number of patients, both morning and evening in a heavily burdened machine is always not possible. But sometimes if in certain situations where, especially as you said, if it has already been having complicated with previous surgeries or previous radiations, then in such situations, the long-term toxicities, if it is a concern, probably we can consider hyperfractionation, but not as a routine.
Sir, there are a couple of questions not related to today's topic. One of them wants to know, is PNI considered as an independent factor while deciding on adjuvant therapy?
Okay. There is something called as soft factors like PNI, lymphovascular invasion. Independently, they are not considered as a risk factor for adjuvant treatment. But when it is present with any of the other ones, combined together, they can be taken together as an indication for adjuvant radiotherapy. And recently, we have started a trial that's called the ARREST trial, which have looked into this, whether considering this soft factors like lymphovascular invasion and perineural invasion to be considered for adjuvant treatment. So as such, as of now, it's not a classical indication alone for radiotherapy.
Thank you. So one last question. In a recurrent tumor on the same site, would you consider opposite neck dissection? This is not related to today's topic. This is the other question.
Again, it has to be tailored. If it is if the both sides have received radiotherapy earlier, And if it is a chemoradiotherapy and a plaster neck, if it's a small nodal recurrence, usually a super selective neck dissection is enough. But if it is a large node and the other side is not dissected and not given radiotherapy, maybe we can consider doing the other side neck dissection also, because that is the next level where the patient can recover. Depends on the situation, and the decision has to be taken in a combined modality, tumor board discussion.
Thank you, sir. Thank you so much.
So, KK sir, I just have one question.
Yeah.
So a patient with a carcinoma tongue,
Right.
now the depth has incorporated into the staging system. More than 5 mm, it automatically get upstage as T3 and it mandates adjuvant therapy. The situations in which post-op histopathology shows that the depth of invasion is 4.5 mm, and there are no high-risk features on the primary as well as node. Only factor is depth is 4.5 mm. And a tongue primary. In this situation, would you advise adjuvant therapy? And if so, what will be the adjuvant therapy?
No. As of now, 4.5 millimeter depth, saying that it is T2, right? 4.5
T2, yeah.
As of now, it is not an indication. Previously, even for 10 millimeter, we never used to give radiotherapy, and Tata used to give radiotherapy for 10 millimeter. But now that more than 10 millimeter is T3, it becomes T3 and stage 3. Maybe we are sort of considering it for an adjuvant treatment. But 4.5 as of now is not an indication. But again, this will be answered by this particular arrest trial. And there are definite papers, even though this T3, it improve the, there is a survival difference. That's why they have changed it into T3. But whether this survival difference was resulted because of giving adjuvant treatment is not from the literature. So they have changed upstage to T3 because there was a survival difference for those tumors more than 10 millimeter. But whether this survival difference was a result of that adjuvant treatment, it's not clear from the literature.
Okay, sure, sir. I think Azhar sir wanted to make a point.
Yes, Azhar.
Hello?
Hello, sir.
Can you hear me? Yeah, nice presentation. Really a difficult talk to keep yourself confined to neck, not to cover the orbital cavity things. Excellent talk. I just want to end with this depth thing. Depth thing issue is that the depth as such in isolation does not have prognosis till 10 millimeters. Means if you got a T1, T2 case up to 10 millimeters, there's no need of adjuvant treatment. And the paper came last year. It was a multi-center paper. There were a lot of guys came in probably had a neck. They looked into depth in isolation. They said no. Once it gets more than 15, more than 10, then it had some sort of. But there's one drawback to it. They didn't consider the LVI or the PNI in it. So there's one drawback there in that paper. But as such, there's a lovely paper, a landmark paper published last year, I think, in January, which looked into this depth, and it was probably only up to 10 millimeters if they found some sort of effect, not beyond 10. I mean, beyond 10, you can consider RT, but not below 10 millimeters.
Right.
Sir, one more question has been asked. They want to know if the upper mediastinal nodes are covered in cervical esophagus or postcricoid primaries.
Probably yes. Anu will be the right person to answer that.
Cervical esophagus, it is at rest. Upper mediastinal nodes are at rest.
Correct. Yes. Any other questions?
I think for the moment, that's the question.
Right.
That's all.
Thank you, Akshay. Excellent session.
Right, so thanks a lot.
Thank you very much.
Yeah, looking forward for further more participation in our webinar, sir.
Sure.
And next, Vivek, do you want to close the session, summarize it?
Yeah. So I think sir has explained all the points. Probably the only time when we can consider observation is when there is a single small node, less than 3 centimeters. And also that depends on how big the primary is. And otherwise, if there are more than one node or any node more than 3 centimeters, definitely requires adjuvant radiation. And chemotherapy, preferably cisplatin in a 3-weekly cycle, needs to be added when there is extracapsular extension or when there are multiple nodes, low-lying nodes positive. So with this, I'd like to thank Sir, thank Dr. Anup, and thank Akshay for very well organized and very informative webinar. Thank you, sir.
Thank you, everyone. Thank you. Thank you, Anup, too. Anup, thank you.
Okay, sir.
Yeah, thanks, Anup sir. Yeah, thanks, Anup sir, for pitching in.
Bye, Akshay.
Bye, sir. So next Thursday, we have our webinar on molecular basis for neck metastasis by Professor Vishal. So that is on the 18th of June between 8 to 9. Looking forward to everyone's participation. And thank you, KK sir and Vivek, for joining in and making this a very fruitful discussion. Thanks.
Thank you. Thank you. Thank you.
And we also have in the Bhargav's head and neck webinar series that beyond conventional free flaps. So that is on 7th of June between 6 to 7. So it's a very, it will be a very interesting session as well.
Sir.